Today is self-expanding metal stents in the malignant and benign biliary strictures. The first is, of course, the malignant stricture, because we are in the Oncology Institute. And for the first, malignant biliary stricture are caused not only by a direct infiltration, but also caused by another things. That means the intrinsic compression. Intrinsic compression may from the lymph nodes adjacent to the duodenum or to the hilum, inflammation, lymph node metastasis, hilar and periduodenal, and desmoplastic reaction from tumors after chemotherapy or radiochemotherapy. We divided the strictures in two parts, of course, because the treatment and strategy for the treatment is different. The distal malignant strictures are caused usually by pancreatic cancer or lymph node metastasis, or bile duct cancer in the distal bile ducts. And the proximal malignant stricture, they are most difficult to stent it. There is gallbladder cancer, Klatskin tumor, which involve the hilum, and of course lymph node metastasis and liver metastasis by itself, or liver tumors. The first report on animal study with the percutaneous insertion of the self-expanding stent was published in 1985, and it was a stent adopted from the vascular surgery and vascular mini-invasive surgery, of course of larger diameter, and it was a stent which for a decade almost was a model for the next stent. It was the wall stent by Schneider. 4 years later, a first European trial used another stent coming from the US. It is a special Gianturco expandable metal stents, also adopted from vascular mini-invasive procedures, were published, and another one in radiology in 1990 when the first publication concerning the hilar stenting with expandable transhepatic metallic stent were published. There are all uncovered stents, but first implantation by endoscopy was performed in Germany and in Holland, and Neuhaus and Ibretz in the same time reported almost the same number of patients where the wall stent by Schneider were implanted endoscopically into the bile duct. Another stent which is not here represented is the Strecker stent from United States. Strecker stents were plotted stent which required a very aggressive balloon dilatation after introduction into bile duct, because they don't have an own radial force enough to have a proper diameter. Before we talk about the procedures, we must talk a little about the diagnostic procedures before invasive endoscopic procedures like the stenting by itself. In the past, that means in the 80s, we performed the clinical evaluation of the patient, ultrasonography, RCP as a diagnostic procedure, and then very rarely CT scan, endoscopic ultrasonography, which appears in the 80s, and on the end MRE and MRCP and the last procedures. Today, the endoscopic procedures, like here, are on the last position, because before we start with endoscopy and any invasive procedure, mini-invasive, we must perform all diagnostic procedure and clinical evaluation for proper planning of the treatment. And this is very important. There is a courtesy of my friend, Professor Pacho from Warsaw. There is a Klatskin tumor, which clearly shows that if we start with endoscopy, we have at least 3 main ducts to drain, or choose the 2 ducts to drain concerning the volume of the liver, because we know now from the retrospective and prospective evaluation that at least 50% of the volume of the liver should be drained to achieve a proper decompression and the proper function of the liver. It changed in the years because before they say that only 1 duct can be drained. Of course, it's possible when the tumor not involve the confluence and this teeny parts of the main hepatic ducts. So, if we see such picture, we must know that not only endoscopy can be used in such manner. We must provide also a possibility of percutaneous transhepatic procedures to achieve a proper result. So the precise evaluation of the radical treatment possibilities must be evaluated before we start. Not all patients sent for endoscopy because of their jaundice should be treated by endoscopy. And we must remember that in pancreatic tumor, there are the patients who can be operated on. And of course, they are not in this picture, in these slides, because this is not concerning about a self-expanding stent, maybe a little bit, but in the works published recently about the preoperative drainage of the bile duct in pancreatic cancer, we must use also a self-expanding removable stent only in manner when the patient cannot be operated in a very short time. It could happen in the different settings. That means that, for example, cardiovascular insufficiency, or not possible to have an operating time, operating planning, and in such manner, such patient suitable for the radical treatment can be treated by endoscopy for the time to the operation, but also we should use a self-expanding stent instead of plastic stent, because the prospective papers say that when we use the plastic stents, the percentage of complications occur more frequent after the radical pancreatoduodenectomy instead of use of self-expanding stent. So first, we must know that this patient is only sent for palliative treatment. We prefer the self-expanding metallic stent in the bile duct in the patients which provided survival is more than 4 months. If we have the patients in the very poor conditions and we see and we think that survival of this patient is less than 4 months, we can use the plastic stent because usually they work properly in that time. And the cost of the plastic stents are of course less than the self-expanding metallic stent.
Прошу прощения, нужно ли перевести, потому что до этого классификация, скажем так, была в уровне сужения. Значит, о чем сейчас идет речь? Что у пациентов, которые подлежат хирургическому лечению, не обязательно проводить стентирование. Почему? Потому что доказано, что разрешать желтуху, операция фронт несет меньше осложнений, чем стентирование или наружное дренирование. У пациентов, которые могут подлежать операции, если речь идет о панкреатическом раке. Самооткрывающиеся металлические стенты с целью паллиации, да, с целью, должны устанавливаться пациентам в хорошем функциональном состоянии, которые не операбельны, но их ожидаемая продолжительность жизни превышает 4 месяца. Почему? Они дороже, при них больше осложнений, да, результат лучше, но эта процедура должна использоваться с тем, чтобы ее эффект был длительным. Если же ожидаемая продолжительность жизни меньше 4 месяцев, или же пациенту нужно разрешить механическую желтуху, там выше 200 уровней билирубина, и все-таки подготовить его к операции, лучше всего использовать пластиковые стенты. Их использование, во-первых, дешевле, во-вторых, сопряжено с меньшим риском осложнений.
It is about the cost of treatment, because we count the cost and know that it is, we are able to put in the patients everything.
Да.
It must be done with the use of your brain.
Используйте, скажем так, мышление для того, чтобы не тратить зря деньги пациента. То есть мы технически можем ему установить все, но насколько оно ему поможет и насколько это будет оправдана трата, скажем, средств пациента.
Okay, and then further, there is no statistic from the different works conducted in the 20th century between uncovered and covered stents. These works are regarding to the effectivity of the drainage and the frequency of complication, like a migration of the stent or occlusion of the stent. So from these works we know then when we use uncovered stent and covered stent, especially in the distal stricture, we achieve the same results.
Исследования не показали статистически значимые разницы между покрытыми и непокрытыми стентами. Ни в частоте миграции, ни в частоте окклюзии. Вот.
Предистальных опухолей?
Предистальных.
Да, предистальных опухолях.
Okay, there are the quite simple cases. Of course, if you have a good access, there are the distal pancreatic cancer with the short stricture. As I show you today on the movie, we do not delay such stricture. We try to insert the stent before, not to delay it too much, to prevent the occlusion. And the second is common bile duct neoplasm involving the common bile duct and the distal part of the common hepatic duct and drain with one covered stent.
Сверху представлен один покрытый стент при дистальной опухоли общего желчного протока и excuse me.
No.
One more time about
the pancreatic stent we don't use an excessive dilatation, only to the passage of the delivery system of the stent, which is usually smooth, and release the stent, not to delay it.
Не было попыток расширить путь для установки стента перед его собственной установкой. Он сам откроется в просвете до нужного диаметра. И это будет способствовать лучшей фиксации стента вместе. Да.
Okay. Okay. Now, the cholangiocarcinoma. There are cases from the past, more than 10 years. As you can see from endoscopy, it is we are able to contrast the left and right hepatic duct with the very tight stricture in the confluence and both hepatic ducts. So we are able to go to the left hepatic duct on the first picture. Sorry. You can see the stricture of the left hepatic duct and common hepatic duct and the confluence. Here is the right hepatic duct. From endoscopy you are able to pass to the left hepatic duct and place an uncovered silver stent. This is metal stent properly, but we are not able to pass to the right hepatic duct. For that purpose we use a percutaneous transhepatic approach, and we are able to pass through the stent, through the mesh, delay the stent, the mesh of the stent to the needed diameter, and insert a second wall stent uncovered also through the mesh of the first stent. So, as you see in the previous picture, the imaging, that means non-invasive imaging, can lead us to the provided two-step or two different techniques for drainage of the hilum.
В данном случае представлена комбинированная методика дренирования билиарного дерева. Здесь были трудности в, скажем так, нельзя было попасть в сейчас хорошо был общий и правый проток, поэтому использовались два стента, причем для того, чтобы провести второй стент, заводилось устройство, которое расширило проток за стентом, и по первому стенту был заведен следующий стент.
And this is stent-in-stent technique.
Техника стент-в-стент.
This is another case when we use endoscopic stenting. This is a patient, 78 years old, after a distal gastrectomy before 2 years before endoscopic procedure due to gastric cancer with bilirubin 2 reconstruction of the gastrointestinal tract. So you can see here the picture from the duodenoscope, but we are not able to go with the duodenoscope to the afferent loop, and we use then therapeutic gastroscope with a cap of the tip. This is a trick which helps you to achieve the papilla and stabilize the papilla in this inverted anatomy.
Значит, пациент после резекции желудка по билирубин 2, и до эндоскопа не было возможности прийти в приводящую петлю, поэтому использовался гастроскоп.
Large channel gastroscope, but this is important thing for treatment, not for a diagnostic, but for a treatment, because with this cup I was able to stabilize the papilla and cannulate the bile duct.
в такой способ было легче стабилизировать папиллу и канюлировать билиарное дерево.
On the CT imaging, we know that the problem is in the hilum, and it's confirmed by endoscopy. So it is the stenosis of the common hepatic duct and part of the right hepatic duct, and further left hepatic duct, which is seen here.
Тут видим стеноз правого печеночного отсека.
Sphincterotomy is done, of course, with the inverted sphincterotomy specially designed for these purposes. And the second guide wire is placed in the left hepatic duct. So first we use here the technique of the stent-in-stent introduction. This is a special Y stent which mesh is in the center of the stent larger than normal. These cells are in the larger diameter. So we first introduce the stent in the duct, which has a better situation. So we try to put the stent and have these cells larger open for the possibility to go to the right.
Применена хитрость. Сначала установлен один стенд по протоку, который легко проходим, расширился до большого диаметра, и потом появилась возможность через большую ячейку в сетке стента провести второй стенд по типу буквы Y. Вот, для того, чтобы тренировать правую.
This procedure was performed in the January or February this year. And now this patient came for a control, and now we see that we must check this stents, but it's almost 10 months free of symptoms and free of jaundice. Of course, this first stent is completely in the bile duct, and this one is going to the duodenum. So probably the uncovered stent we are able to go to the one and to the right and the left hepatic duct.
Значит, пациент пошел на контроль через 3 месяца после этой процедуры. Процедура была проведена в этом году. Признаков желтухи нет. И,
10 months.
10 месяцев. В феврале этого года была проведена процедура, и желтуха не рецидивировала.
Okay. But of course there are very useful things like you can see, but we must every time concern the potential adverse events. There are two techniques of stenting the hilum and the intrahepatic duct, and of course we can use different stents. The stents of the different diameter, and first is shown already the stent-in-stent technique, but the second one is stent by stent. That means that we introduce the stent each by one, first to the left, then parallel to the right side. And as you can see, the possible compressions of the vessels, adjacent vessels, mainly the portal vein, can lead to the thrombosis of the portal vein or acute liver failure. It happens in our material too. Bile-borne necrosis with the perforation, it happens too. Compression of patent cystic duct and compression of segmental duct. So you can see that this stent is placed in the right hepatic duct and is not completely opened. He compressed the segmental ducts, and we must perform later in this patient's percutaneous transhepatic approach to achieve relief of the cholestasis from the right hepatic duct. And the same situation is here. You can see that this stent is completely pressed by the second located on the right hepatic duct, and in the same situation we must use the percutaneous transhepatic approach to relieve the jaundice.
Значит, здесь представлены осложнения установки двух стентов. Они включают в себя возможность сдавления как сосудов которые проходят в той зоне, так и протоков печени. Плюс не забываем о возможности некроза при наличии 2 стентов в просвете желчного протока, некроза стенки. Значит, на первой картинке 2 стента стоят параллельно, и этот случай осложнился первым из описанных осложнений. Значит,
this stent is not completely open and separate the segmental duct.
На третьем слайде стент не открылся полностью, стоит возле суженного правого печеночного протока.
Okay. And the most immediate result is acute cholecystitis due to compression of the patent cystic duct. Not in this case, but it happens also, and this leads for emergency operation or drainage.
И нельзя забывать о возможной вероятной окклюзии пузырного протока, который приведет к острому холециститу и необходимости ургентной операции по поводу острого холецистита.
Okay. And another failure, we performed this examination and treatment in the lady after the resection of the colon due to the cancer, and then non-anatomical excision almost the whole left liver lobe due to metastasis. And he came with the jaundice and known metastasis on the right lobe. We inject the contrast. We can see a very nice picture of the hepatic duct in the right lobe, and we insert the stent. It was an uncovered stent, and you can see that after the deployment the resolution of the contrast in the bile duct appeared. But 4 weeks later we achieve jaundice again, and on the ultrasound and CT we can see the dilated low the hepatic duct. That means that's a 6 and 8 segment, and as you can see we must use the percutaneous transhepatic approach, because this stent, when he achieves a complete diameter, compress the secondary ducts and lead to the failure of the
Интересный
drainage.
случай. Пациентка оперирована по поводу рака толстого. Пациентке возобновилась желтуха. И теперь видим, что стент, когда раскрывшись дальше, перекрыл правый проток. Вот, и привело желтухи с другой стороны.
Lower, because there are the segments drained by the stent, but there are in the high it is 7 and 5. This is 8 and 6. So we must also
Восьмой и
think.
шестой сегменты оказались отключенными за счет раскрытия стента.
And treatment by a percutaneous transhepatic drainage as well. Potential problems again. This stent is good placed in the pancreatic cancer, involve proximal part of the common bile duct. As you can see, the stent is properly located, the drainage achieved, but the problem is that in this curve, this stent is compressed. And now for the follow-up, we know that he never reached the diameter who we need.
В данном случае другое осложнение. При правильном, нормально установленном стенте за счет сильного изгиба мы понимаем, что он не сможет раскрыться полностью. Это не приведет к полноценному разрешению желтухи.
Okay. And the second stent, you can see this probably on the previous picture, the short stenosis due to pancreatic cancer in the common bile duct. We insert the stent and look what happens. The stent straightened after deployment, and here is the direction of the common hepatic duct, and here is the direction of the stent. What happens is this is like a completely covered stent. So he touched the wall of the common hepatic duct, and it's occluded.
Здесь тоже
Even when it's completely open.
Казалось бы, простая ситуация, короткий стеноз дистального отдела холедока головкой поджелудочной железы, установлен стенд, который раскрылся. Однако, учитывая направление хода холедока и направление самого стента, произошло это полностью покрытый стенд. Он как бы сложился в протоке и с собой закрыл просвет холедока. Вот, при, казалось бы, правильно и удачно проведенной процедуре.
Okay. So for that, Japanese author, Professor Yaman, provided a very interesting work in 2009, published in gastrointestinal endoscopy. They tested 14 different stents, covered and uncovered, and very shortly I try to explain what happens. The main manufacturers and we, as endoscopists, deal only with the radial force. That means the opening of the stent. And, of course, the resistance force. That means when we have a desmoplastic stricture, that we try to provide it not to compress by a tumor, or flexibility. And the secondary things which happen during the procedure, that means the shortening ratio, how many the stent shortens during the deployment, radiopacity, how we can see the stent, and trackability, that means how we are able easy to release the stent.
Значит, когда устанавливается стенд, действует радиальная сила, которая способствует его. Ну, производители учитывали два момента: сдавление снаружи опухоли и способность стента к раскрытию, это сила, которая действует на раскрытие. Никто не учитывал возможные изгибы и возможные варианты расправления стента в том или ином просвете.
Okay. And these parameters, the whole manufacturers report on the package of the stent. The radial force is provided, published, and known very well. But, undepending on the construction of the stent and the material of the stent, you can see some samples how the stent are plotted. Because some there are machine plotted, some there are laser cut wire, some are braided, and you know, independently of this manner, the problem appears with the axial force. Axial force, this is the force of the stent appeared in the length of the stent. What happens when the stent is deployed?
Сейчас, секунду. Есть три параметра, которые указывают на упаковках стентов. Да? Длина, там, визуализация на рентгене, возможность к удалению. Значит, при любом способе изготовления стента есть вероятность тех явлений, которые хорошо были видны на слайдах, то есть каких-то деформаций. При этом, скажем так, не учитывается способность стента расширяться, учитывается возможность стента расширяться только в диаметре, но не учитывает аксиальную силу, которая направлена по оси стента.
And this axial force is depending and change with the length of the stent. So, if the stent is very long, 10 or 8 centimeters, this axial force change in the stent with its length. So it's not the same in every point of the stent. If this force is too high, they can lead to different adverse events, like kinking of the stent and moving of the stent, and also tendency to migration.
Значит, в чем суть? Что за счет этих явлений сила, направленная радиально, не одинакова на каждом из участков стента покрытого. Кроме того, скажем, нельзя полностью учесть возможность сморщивания стента, гофрирования стента в просвете. Соответственно, не будет действовать радиально сила, направленная на расширение суженного участка, одинаково по всей длине стента.
Okay, maybe not to comment these pictures because they are very difficult to comment, but as you can see, in almost all stents, this resistance force, this curve, is almost the same. This one only differs in the special, very soft stent. This depends the radial force, and this depends the covered stent in the same situation. As you can see, the covering and type of covering, as well as the material of covering, play an important role if the expansion force as well as the resistance force for the compression of the stent after deployment. So if you choose the stent, you must think also not only what material is in the stent, but how it is covered. For that reason, you must choose the stent for the malignant disease, which is optimal in your settings. The uncovered stent has a better comparison between RF and AF than covered stent. So,
значит, решающую роль в этих взаимодействиях играет покрытие стента. Поэтому, скажем так, и к выбору стента надо подходить индивидуально в каждом случае, для каждого пациента, для каждой конкретной ситуации. Для злокачественных, если я правильно понял, новообразований предпочтительнее выбирать непокрытые стенты, non-covered stents.
For the beginning.
Для начала.
For the beginning. Okay, now shortly to the benign biliary strictures, because the hot topics in the last years. Of course, the common causes for this is postoperative injury like leaks or strictures, chronic pancreatitis, and the most common biliary complication after liver transplantation.
Значит, в отношении доброкачественных болезней билиарного дерева, значит, обычные причины это повреждения во время операций. Вот, и вторая группа есть после развития структур, после трансплантации печени.
This problem should be solved for years by stenting with multiple plastic stents, but all these works are very good and have a very good results, but no of them has more than 30 patients. The biggest one is work from Costamagna in Rome, then 36 patients, but only with chronic pancreatitis, not another strictures.
Значит, по поводу структур. Есть множество работ, которые успешно лечатся установкой множества пластиковых стентов, да, пластиковых трубок, просвет расширяет. Но недостаток. Ни в одной работе нет, самая большая работа на 36 пациентов, причем лечили хронический панкреатит.
Okay. So in the 2008, the first papers concerning the temporary placement of covered self-expander removable stents appears, and was of course first papers in 2007, and different settings of the stent were used in this treatment.
Значит, перспективу видят в использовании покрытых самораскрывающихся металлических стентов.
This work, this year, 2012, you have probably this in endoscopy published in October. This is a very large paper from Italy, then 67 patients treated with fully covered expandable stent with only one failure and 4 recurrent strictures. When, as we compare that with the plastic stents, it's very, very promising message.
Значит, ожидается публикация исследования на 67 пациентах с успешным применением и только одной рестриктурой при применении покрытых самораскрывающихся стентов при доброкачественных структурах. Вот.
Okay, and this is some cases of our department. This is a young lady after the liver transplantation with a known from 2009 stricture of the anastomosis and very large left hepatic duct. And in this duct, the stone appeared, like here. We try, and here very good. We are not able to crush the stone, to catch the stone. The self-expanding removable stent were applied, and then after 3 months we are able to remove the stone, and duct is completely healed, and no stenosis appeared.
Проблема была в том, что камень извлечь с помощью пластикового стента было нереально. Был установлен самораскрывающийся стент, и появилась возможность для извлечения. Ну, камень вышел сам.
Okay, post-cholecystectomy stricture, usually post-laparoscopic cholecystectomy. Here in the common hepatic duct, you can see as a primary treatment, we use covered fully stent implanted here and remove after 4 months, as you can see, a very smooth and good diameter of the common hepatic duct. So it was really very fast treatment.
Здесь положительный пример лечения покрытым стентом с последующим извлечением через 4 месяца стриктуры после лапароскопической холецистектомии в среднем отделе Халедаха.
Okay, and this is another case, several approach with the plastic stents. You can see that we stented it with 2, 3 stents, 4 stents, without any results. The stricture were still observed. Then we insert a fully covered expandable stent, and this in September, in November, in December we are able to remove the stent, and you can see the outflow of the bile duct, and the diameter of the bile duct were quite good.
Безуспешного лечения пациента с помощью пластиковых стентов с последующей установкой покрытого металлического стента и последующим извлечением через 3 месяца хорошим результатом.
And a very difficult case for us also, this is a lady 73 years old after pancreatoduodenectomy due to pancreatic cancer. 3 years after the procedure, he developed cholangitis and jaundice. We performed this examination also with a therapeutic gastroscope. With very difficulties, we found a very thin bilio-anterior anastomosis. As you can see, we use a balloon for the dilation, and after that we achieve a lumen and inserted 8 mm self-expanding methane stent covering, and 3 months later we were able to remove the stent, clean the bile duct from the stones, and this is the diameter of the anastomosis after treatment.
Пациентка после панкреатодуоденальной резекции, да, и использован тот же прием не дуоденоскопом, а гастроскопом. Найдена приводящая петля, с большим трудом найден анастомоз между билиарным деревом и кишкой. Сначала проведено его бужирование, затем заведен покрытый металлический стент. Удалось разрешить и холангит, и желтуху у пациентки. В последующем стент извлечен, пациентка, поставленный результат достигнут.
Okay, and unfortunately, adverse events. There is no fire, no smoke. There is a case of a doctor after a very long-timing acute pancreatitis with debridement of the necrosis. He developed a stricture of the common bile duct. We insert, after failure of the plastic stent, self-expanding stent, was broken. You can see here and here the part of the stent, of course the upper part of the stent, in the bile duct inside, of course the jaundice, the cholangitis appear again, And here you can see the stent which we are able to remove from the bile duct.
Здесь случай поломки стента внутри билиарного дерева. Естественно, физически его достать удалось. Картинка в правом углу экрана.
So this patient is sent for the operative treatment again. The second, this is a patient after the liver transplantation. We performed RCPs several times. We always received a picture of the left bile duct very large, the small right hepatic duct, a lot of stones in every approach in the bile duct, and finally we decided to implant the stent to the common hepatic duct of the donors, that means the transplanted liver. And in this first picture it looks very nice.
Здесь пациент после трансплантации печени с внутрипеченочным холедохолитиазом. Вот, и разрешить его удалось установкой покрытого стента.
So she came 4 months later as scheduled for treatment, further treatment without jaundice, with one episode of cholangitis recently developed, and we try to remove the stent unsuccessfully. We are not able to remove the stent. Probably this stent was moved down from this place here, and we are able to move around the stent, not inside the stent. But it's no problem to go inside the stent, but around the stent, pull the balloon, and we try to release this proximal part of the stent unsuccessfully, and two plastic stent were inserted not through the stent, but parallel to the self-expanding stent. We are not able to explain why we are not able to remove the stent.
Попытка извлечения у этого пациента через 3 месяца, у него были хорошие результаты, но попытка извлечения была безуспешной, несмотря на все приемы. И объяснить пациенту, почему, скажем так, это не удалось, не представлялось возможным. Поэтому был заведен обычный пластиковый стенд параллельно. Excuse me, for what purpose you put a plastic stent near the...
Because here we developed the stricture again.
Возникла структура выше установленного стента, и пришлось ставить стенд пластиковый параллельно этому выше структуры.
This is my last picture, and to your take-home message is so that the self-expanding stents are very useful things.
Значит, основной месседж лекции в том, что покрытые самораскрывающиеся стенты очень полезная штука.
But we must take care what we are proposed to the patients and what stent we try to implant.
Вот. Но мы должны понимать, что мы предлагаем пациенту, для какой цели и какую цель мы преследуем в каждом конкретном случае, и выбирать подходящий стенд для этой цели.
Like surgeons, because I know that you are also a surgeon, planned the procedures, we must only plan our procedures. So we must have all imaging before the treatment and before we start.
Значит, очень важно то, что РХПГ не является, скажем так, это должна быть процедура последней, когда пациент в полной мере обследован, и мы можем планировать эндоскопическое лечение. Эндоскопическое лечение должно проводиться только имея полную адекватную картину. Это или КТ-сканы, или МРТ-холангиографию, для того, чтобы иметь или МРТ этой зоны, холангиографии все равно надо сделать. Вот, и только потом планировать эндоскопическое лечение, а не делать РХПГ на втором этапе после УЗИ.
Self-expanding stents, in our experience, are very useful also in benign strictures. self-expanding stents are very useful in the benign strictures.
И при доброкачественных стриктурах использование самораскрывающихся покрытых стентов также возможно и дает хорошие результаты.
But as you can see, we have also pitfalls and failures.
Однако, несмотря на это, даже в случае их применения мы имеем досадные, скажем так, осложнения.
And in fact, we are not able to provide how to prevent it.
И, к сожалению, мы пока не знаем, как мы можем их предотвратить.
Thank you very much for your attention.